Hello, friends, and welcome back to Expertly Weird, the corner of the internet where we curl up with stories that are equal parts curious, unsettling, and sometimes a little bloody. Tonight's story has the mood of a late-night fireside chat, the kind where you pull the blanket up to your chin and lean in because you know something strange is coming. We're talking about surgery, not the clean, humming, beeping kind you know today. No polished instruments, no sterile gloves. We're going back to the centuries when people, doctors, only in the loosest sense, cut, stitched, burned, and prayed their way through the human body. It's the kind of tale that makes you whisper, "How did anyone survive this?" and then keeps you listening anyway. Cozy enough for bedtime, but not exactly sleep-friendly. So settle in, get comfortable, and let's drift back through the centuries to a time when going under the knife was about as pleasant as a bear attack, and often just as deadly. It is late in the Stone Age, long before anyone spoke the word surgery. A hut made of mud and thatch leans against the wind. Smoke from the cooking hearth seeps out through the roof and clings to the thatching so that the air smells of damp ash and cooked roots. Inside, a man lies on a reed mat with his hands clamped over his skull. The villagers believe he is cursed. Some say a demon has crawled into his head. Others believe the gods are punishing him for stepping on sacred ground. His eyes squeeze shut with pain. His breath comes in short huffs. Beside him kneels the village healer, a wiry figure with hair braided back with strips of rawhide. His fingers are stained dark from grinding herbs. In his palm lies a shard of flint, chipped thin until the edge gleams like frozen water. He believes the only way to save the man is to give the spirit inside his head a door to leave through. Without ceremony, with only a few murmured words to the ancestors, he places the sharp edge to the skull and begins to scrape in slow circles. There is no antiseptic, no understanding of germs, no such thing as anesthesia. The man's brother grips his arms to keep him still. The healer pauses now and then to spit on the rock, to brush away flakes of bone, to whisper something no one else can hear. The smell in the hut is a mixture of sweat, smoke, and blood. We would expect this to end in death, yet centuries later, archaeologists would dig up skulls with neat round holes and smooth ridges of new bone growing around the edges. Those ridges proved that many of these patients lived. The practice even had a name, trepanation, and it existed in cultures scattered across the globe. From the plains of prehistory, the story moves to the banks of the Nile around 2500 BCE. The air is hot, bright as polished bronze, and smells of wet reeds and river mud. This is the world of pharaohs and pyramids, but also of healers who were astonishingly practical for their time. In a cool mud brick room, a physician unwraps his kit, a splint made of palm sticks bound with linen, a bronze needle curved like a fishhook, a tiny clay jar of honey dark as amber. He has read the instructions on a scroll known as the Eber's Papyrus, a catalogue of more than 700 remedies. He knows to wash a wound with beer, to bind a fracture so the bones stay straight, to smear honey across a gash because it keeps rot from spreading. Though he doesn't know the word bacteria yet, picture a boy brought in from the fields, with his arm broken by a falling stone. The healer soaks strips of linen in resin, wraps them tight, and sets the arm straight with reeds. The boy's father brings a jug of beer, steeped with crushed opium poppy, to dull the pain. If the family's poor, the boy gets plain beer and must grit his teeth. The Nile flows on outside, steady and indifferent, while in that small room an idea is born, that the body can be repaired with knowledge rather than luck. East of here, in the bustling ancient cities of the Indian subcontinent, a surgeon named Sushruta teaches generations of students beneath the shade of fig trees. Around 600 BCE, he compiles his lessons in the Sushruta Samhita, describing more than 300 operations and over 100 different instruments. One of his most remarkable procedures is the reconstruction of a nose, a grim necessity in a society where amputation of the nose was used as punishment for certain crimes. Imagine the courtyard where the surgery is performed. The patient lies on a woven cot, a damp cloth covering his eyes. The air smells of clay dust and clarified butter burning in a lamp. Sushruta gently lifts a flap of skin from the patient's own cheek or forehead and shapes it into a new nose, stitching it with thread spun from plant fibres. There is no anesthetic beyond a few bitter herbs, but there is skill, and that skill sometimes saves a face and a life. In ancient China, a healer named Hua Tuo in the 2nd century CE becomes famous for discovering a mixture of herbs called ma fei sun that could send a patient into a deep, painless sleep. The recipe will be lost to time, but the stories linger. Soldiers lulled into slumber before having abscesses drained, villagers soothed before a tumour was cut away. Chinese healers sometimes poured strong rice wine over wounds, burned sticks of cannabis-rich incense to dull pain, and placed fine needles along the body's meridians to distract the mind while the blade did its work. Farther west, in Babylon and the old cities of Mesopotamia, sickness is still believed to be the anger of gods. A wounded man is stretched out on a reed mat under the flicker of an oil lamp. A priest-physician kneels beside him, bronze needle in one hand, the other raised in prayer. He dips the needle in fragrant oil, stitches the flesh, and then sprinkles powdered herbs over the wound, while whispering charms to drive away demons. Here, the sacred and the surgical share the same space. A patient's survival is credited as much to the gods as to the healer's hands. Across these ancient worlds, one thread stays unbroken. People will risk the cut if it means a chance to live. They will endure a sharpened stone pressed against the skull, a crude splint wrapped in reeds, a flap of skin cut and sewn into a new shape, a mouthful of bitter wine that barely numbs the pain. They survive often enough for the knowledge to outlive them, carried forward not by books alone, but by the memories of apprentices and the stories of families who saw a loved one healed against the odds. That stubborn desire to keep going, to fight injury and illness with tools, prayers, and ingenuity, is what allowed surgery to survive the march of time. As centuries passed and empires rose and fell, the practical wisdom of these early healers was not always preserved. When Europe slipped into the long medieval period, much of the old learning was forgotten or ignored, and the knife passed from scholars to barbers. The next chapter of the story grows darker, rougher, and far more dangerous. When the classical empires fell and Europe entered the long medieval centuries, much of the hard-won medical knowledge of Egypt, Greece, India, and China faded from daily use in the West. Libraries were lost in wars and fires. Texts were locked in monasteries written in Latin few could read, and even where the old ideas survived on parchment, superstition often replaced practical skill. Care of the sick shifted away from learned physicians to local healers, barbers, monks, and midwives. Surgery, which had never been highly regarded by university doctors, became a rough trade practiced by whoever was willing to cut. Imagine a small village in the 10th century. The air in the timber-walled huts smells of damp wool and smoke from the cooking fire that smoulders in the centre of the floor. Light filters in through a single narrow window or the open door. At night, a tallow candle or rushlight throws a weak yellow glow. A farmer sits hunched on a stool with his sleeve rolled up, feverish from an infected cut on his arm, or a tooth that has turned the side of his face red and swollen. There is no physician for miles, so the family sends for the barber. The barber is both tradesman and healer, known as a barber surgeon. His leather apron smells faintly of shaving soap and lamp oil. The same steel razor he sharpens on a leather strop for trimming beards will now serve as his medical instrument. He carries a small wooden box of tools, razors, shears, a few crude hooks, a small saw, and strips of linen. He believes the man's illness is caused by an imbalance of the four humours: blood, phlegm, yellow bile, and black bile, an ancient Greek idea that still dominates European medicine. To him, the cure is simple: draw off the excess blood. The patient offers his arm. The barber ties a strip of cloth above the elbow to make the vein swell, then nicks it with the razor. A thin stream of dark blood flows into a pewter bowl, while the man clenches his jaw against the pain and dizziness. If leeches are available, They are placed on the skin to drink their fill. This treatment, called bloodletting, is prescribed for everything from headaches and fever to gout and melancholy of the soul. Few people doubt its power. If the patient feels slightly lighter or his fever drops temporarily, it is hailed as proof the remedy works. Outside the shop hangs a wooden pole wrapped with a strip of linen, sometimes newly laundered white, often faintly pink from being washed too many times. This pole becomes the familiar symbol of the barber, the red and white stripes said to represent the blood-stained bandages. Even centuries later, long after barbers stopped performing surgery, that striped pole remained the trade's emblem, a relic of the days when a haircut and an amputation could come from the same hand. But bloodletting was only the beginning. For worse injuries, a mangled leg from a cart accident, a badly broken arm, a gangrenous wound, the barber surgeon was usually the only person available to attempt a major operation. There were no anesthetics. The patient might be given a strong swallow of ale or brandy to dull the edge of pain, and neighbours or relatives would be called in to hold him still. The operating surface might be a wooden kitchen table, the back of the shop, or a plank set on two barrels. The surgeon's only defence against the patient's agony was speed. The best-known operators trained themselves to work with astonishing quickness. Historical accounts speak of men who could remove a leg in less than 30 seconds, from first slice of the knife to final pull of the saw. They prided themselves on how few strokes of the blade were needed. The reasoning was brutal but practical. Every extra moment meant more pain, more blood lost, a higher risk that the patient would go into shock or bleed out before the wound could be closed. Closing the wound rarely involved neat stitches. The common method was cauterization, burning the wound shut. A helper heated an iron rod in the fire until it glowed cherry red, then pressed it to the raw stump. The searing hiss of hot iron on flesh and the acrid smell of scorched blood filled the room, often accompanied by the patient's screams or sudden silence if he fainted. Cauterization sometimes saved lives by sealing blood vessels quickly, but more often it left terrible burns and invited infection later. The concept of invisible microbes had not yet entered anyone's mind. Surgeons worked with bare hands, often wiping their knives on their aprons between patients. Bandages were reused until they stiffened with dried blood. People believed that the appearance of pus in a wound was a healthy sign. They called it laudable pus, thinking it meant the body was expelling bad humours, unaware that it often marked the start of a deadly infection. Countless patients survived the shock of the operation only to die days later from sepsis. This harsh reality extended beyond villages into the battlefields of medieval Europe. After a skirmish, the ground would be scattered with the wounded, the grass darkened with blood. The surgeon-barber moved among them carrying a leather roll of tools, a bone-handled knife, dulled from use, a small bone saw, rough iron forceps for pulling arrowheads, a handful of coarse needles, and a ball of thick thread. There was no morphine, no clean water to irrigate wounds, no sterile field. Soldiers often bled to death where they lay, and more died in the following days from infections than from the swords, arrows, or spears that struck them. While most of Europe struggled with these crude practices, other parts of the world advanced. In the cities of the Islamic Golden Age, Cordoba in Spain, Baghdad and Damascus in the Middle East, physicians preserved and expanded on classical knowledge. They translated Greek and Roman medical texts into Arabic, debated theories, and performed procedures with more refined instruments. One of the most renowned, Abu al-Qasim al-Zahrawi, known in the West as Al-Bukasis, compiled a 30-volume medical encyclopedia in the 10th century. His illustrated manuals depicted scalpels, hooks, forceps, and specialized tools for delicate operations on the eyes, ears, and bladder. Al-Zahrawi treated surgery as a respected discipline requiring skill and study, a vision far ahead of most of medieval Europe, where universities still considered surgeons mere craftsmen. For the ordinary peasant in a fog-drenched European village, such advanced knowledge was little more than a distant rumour carried by merchants along the trade routes. When illness struck, people turned to whoever was near, the barber with his razor, the wise woman with her herbs, the priest with his prayers. Childbirth was dangerous. Infection and bleeding claimed many mothers and infants. A deep wound from farm equipment or from an accident on the road often meant a slow death if the bleeding could not be stopped or if gangrene set in. Survival frequently depended on luck and the patient's own strength rather than on the skill of the healer. This period is often described by historians as the long night of European medicine. It was an age when disease was blamed on sin or on foul air, when suffering was considered part of a divine test, and when the line between healer and butcher was often blurred. Yet despite the danger, people still sought out the barber surgeons. Even a painful, risky attempt at treatment seemed better than doing nothing. Centuries of such rough practice would eventually give way to something different. In the late medieval and early Renaissance periods, curiosity about the body began to stir again. Artists wanted to draw muscles accurately. Scholars questioned old authorities. Step by step, this curiosity would reopen the human body to study, and surgery would begin its slow transformation from a desperate craft into an emerging science. The long medieval centuries of barber surgeons and leeches eventually gave way to a different kind of Europe. Wars still raged, plagues still struck, but curiosity was stirring again. Cities grew busier with trade and wealth, universities flourished, and artists and scientists began to look more closely at the world around them. The change was so dramatic that later generations would call it a rebirth, the Renaissance. In the crowded streets of Florence and Venice, painters wanted to capture the human form with lifelike accuracy, and to do that they needed to know what lay beneath the skin. That artistic hunger for realism would end up reshaping medicine too. One of those artists was Leonardo da Vinci. By day he painted Madonnas and designed machines. By night he bribed the guards at the city morgue for permission to study the bodies of the dead. Working quietly under oil lamps, he drew hearts, vertebrae, the spiral shell of the inner ear, muscles that looked as if they were alive on the page. His notes weren't published in his lifetime, but his observations inspired others to see the body as a marvel of engineering rather than a sealed mystery. At the same time in Padua, a young professor named Andreas Vesalius began to challenge the old medical authorities. For more than 1,000 years, doctors had relied on the writings of Galen, the famous Roman physician, whose anatomical descriptions were treated as unquestionable truth. But Galen had studied mostly animals, apes, pigs, goats, and assumed the same structures existed in humans. Vesalius suspected otherwise. In 1543 he published De Humani Corporis Fabrica, on the fabric of the human body. Its woodcut diagrams corrected dozens of inherited mistakes. Men and women had the same number of ribs. The jaw was one continuous bone, not two. The liver did not pump the blood. In the anatomy theatres of Europe, students crowded onto wooden benches to watch lecturers point out muscles and organs on real cadavers. The smell was sharp and the air cold, but for the first time in centuries, surgeons could study the body with their own eyes instead of memorizing dogma. With better knowledge of arteries and nerves, they could at least avoid some fatal mistakes, even though their tools were still crude, and there was still no way to prevent infection or relieve pain. Beyond Europe, knowledge was advancing too. In Japan, the physician Hanaoka Seishu studied herbal compounds and in 1804 produced a mixture called tsusen-san that allowed him to perform a mastectomy while his patient lay unconscious. It was decades ahead of anything in the West, but the discovery remained largely unknown outside Japan, and so patients elsewhere still faced surgery fully awake. In the Islamic world, the influence of al-Zahrawi's illustrated manuals endured, his carefully described instruments copied for centuries. Yet in most of Europe, surgeons were still considered craftsmen of a lower rank than physicians. Universities gave them little respect. Even so, progress crept forward. Metal instruments became sharper and more specialized. Some surgeons experimented with ligatures, tying off arteries with thread instead of burning them shut with red-hot irons, laying the groundwork for safer operations. The Renaissance turned the human body from a forbidden mystery into something to be mapped, drawn, and understood. It gave surgeons a clearer guide than they had ever had before. But even with these new maps, patients still endured every cut and stitch without relief. Knowledge alone couldn't silence pain. That change would come only centuries later, when an invisible gas would drift across an operating room and for the first time allow the knife to do its work while the patient slept. By the early decades of the 19th century, surgeons had better anatomical maps than ever before, but in most operating rooms the experience for patients was still nearly medieval. A well-trained surgeon might know exactly which artery to tie off or which nerve to avoid, yet the person on the table felt every slice. For all the centuries of progress in drawing and dissecting, the practice of surgery still relied on two things: the speed of the knife and the toughness of the patient. Operations were conducted in whatever daylight a window allowed, sometimes with the audience of medical students pressed so close they could feel the heat rising from the patient's skin. There were no masks, no gloves, no concept of invisible microbes. A surgeon's prestige often came from the steadiness of his hand and the number of limbs he could amputate in an hour. Infection after surgery was so expected that people rarely questioned it. Many still believed that the presence of pus was proof of healing. The first great break in this bleak pattern came not from a hospital, but from a dentist. In 1846 in Boston, William T. G. Morton prepared to demonstrate something astonishing: that a man could be put into a deep, harmless sleep and remain insensible to the surgeon's knife. He used a substance already known to chemists, ether, a volatile liquid that produced a sweet, almost sickly vapour. Morton's patient that day was a man with a neck tumour. The crowd of physicians watched as the patient inhaled the ether through a simple glass inhaler. His eyelids grew heavy, his breathing slowed, he slumped into stillness. Then the surgeon removed the tumour while the man lay motionless, showing no sign of pain. When he awoke, he had no memory of the cutting. To the spectators, it was as though a spell had been cast. News of the demonstration spread rapidly across America and Europe, and within a year ether was being used in operating rooms, wherever surgeons could get their hands on it. The discovery transformed the very rhythm of surgery. Surgeons no longer had to rush to finish before the screams became unbearable. They could slow down, take the time to cut more carefully, explore deeper, attempt operations that would have been unthinkable on a conscious patient. But ether had drawbacks. It irritated the lungs, sometimes caused violent coughing or vomiting, and it was highly flammable, an alarming trait in rooms lit by open flames or oil lamps. Within a few years, another substance entered the scene: chloroform. It was easier to administer, with a more pleasant odour and a smoother effect, and it quickly became popular in Britain. In 1853, Queen Victoria requested chloroform for the birth of her 8th child, lending the practice royal approval and making it fashionable among the upper classes. Yet chloroform, for all its elegance, carried its own danger. In certain doses, it could stop the heart without warning. Doctors now had to weigh the risk of the drug against the certainty of agony without it. Even with these new anaesthetics, another enemy still stalked the operating room: infection. Surgeons could now work more slowly and attempt more complex procedures, but the longer the body lay open, the more chance there was for bacteria to enter the wound. In most hospitals, the instruments were wiped on an apron between patients. The same sponges were used repeatedly. The surgeon's hands were bare and often unwashed. Post-operative fevers and sepsis claimed as many lives as the injuries themselves. The second great breakthrough of the century came from a British surgeon named Joseph Lister. Influenced by the germ theory of Louis Pasteur, Lister became convinced that it wasn't bad air or miasma that caused surgical wounds to rot, but microscopic organisms carried on hands, instruments, and even in the dressings used to cover the wounds. In the 1860s, he began experimenting with carbolic acid as an antiseptic. He sprayed a fine mist of it in the operating theatre, soaked his bandages in it, and washed his hands and instruments with it before every operation. At first his colleagues mocked him. Some hated the harsh smell of carbolic acid. Others simply refused to believe that invisible creatures could be responsible for infections. But the results spoke for themselves. Mortality rates in Lister's wards fell dramatically. The success of his methods slowly forced the surgical world to accept that cleanliness was not merely cosmetic, but life-saving. By the 1880s and 1890s, the combination of anesthesia and antisepsis had changed surgery beyond recognition. Operating rooms were no longer dim side chambers, but dedicated spaces with tiled walls that could be scrubbed clean. Steam sterilization of instruments became routine. Surgeons began to wear freshly laundered white gowns to show they were clean. Rubber gloves, introduced by the American surgeon William Halsted in the late 1880s, originally to protect his scrub nurse fiancée's sensitive skin from harsh disinfectants, soon proved to reduce infections as well, and became standard equipment. These improvements didn't just save lives. They expanded the possibilities of what surgeons dared to attempt. They could now operate on the abdomen, open joints, attempt delicate repairs on arteries and nerves, areas once considered untouchable because infection and shock would almost certainly kill the patient. The operating theatre itself changed character. Instead of a room filled with the cries of conscious patients and the smell of cauterized flesh, it became a quieter, more disciplined environment, where the most dramatic sound was often the steady tick of a clock and the measured instructions of the lead surgeon. Spectators still gathered, however. Many hospitals had purpose-built operating theatres with steeply raked benches, and students crowded so close above the table they could look almost straight down into the wound. The atmosphere combined academic curiosity with something of the morbid fascination of public spectacle. Photographs from the late 19th century show these rooms brightly lit by skylights, surgeons in dark frock coats leaning over the patient while the assistants stand by with trays of gleaming metal instruments. It is difficult to overstate how revolutionary these two discoveries were. For thousands of years, surgery had been a brutal last resort, often deadlier than the illness or injury it was meant to cure. With the advent of anesthesia, the barrier of unbearable pain was finally removed. With antisepsis and later asepsis, the insistence on sterile conditions, the hidden killers that lurked in every wound were at last brought under control. Together, they turned surgery from a desperate gamble into a branch of medicine that could genuinely promise healing. By the final decades of the 19th century, a patient in a modern city hospital could be put safely to sleep, operated on with precision steel instruments, and wake to recover without fever or festering wounds. The transformation was so rapid that older surgeons, who had spent their youth racing to amputate screaming limbs, now found themselves pausing to marvel at the calm and cleanliness of the new era. What had once been a contest of speed and courage had become, almost overnight, a science. This new foundation would open the door to even more daring possibilities in the century to come. Repairing organs instead of removing them, transplanting tissue from one body to another, replacing crude saws with fine scalpels, and eventually allowing machines, and even robots, to lend their precision to the surgeon's skill. But first came the age of electric light, X-rays, blood transfusions, and specialized wards that would carry surgery into the modern world. The turn of the 20th century brought more than a new calendar. It brought light, literal electric light, into operating rooms that for centuries had relied on daylight or gas lamps. Bright bulbs illuminated every movement of the scalpel, eliminating the deep shadows that had made delicate work so difficult. Surgeons now saw clearly into the hollows of the body in a way their predecessors could only have imagined. Another revolution arrived with the discovery of X-rays in 1895 by Wilhelm Röntgen. Suddenly doctors could see broken bones, bullets, or swallowed objects without making a single incision. A fractured limb no longer required guesswork. A hidden abscess or a lodged bullet could be located precisely before the first cut was made. This new power to see inside the living body reduced the number of exploratory surgeries and gave surgeons a confidence that felt almost like a superhuman sense. The new century also brought the classification of blood types by Karl Landsteiner in 1901. Before that, transfusing blood from one person to another had been a deadly gamble. Sometimes the patient rallied, sometimes their body rejected the unfamiliar blood, and they died within minutes. Once doctors understood the ABO groups and how to match them, blood transfusion became a life-saving tool, especially for surgery and wartime medicine. In the 1940s, the development of blood banks meant stored blood could be ready whenever a patient needed it, a quiet advance that saved uncountable lives on the battlefield and in civilian hospitals alike. Perhaps the single most important medical weapon of the mid-century was antibiotics. When penicillin was mass-produced in the 1940s, the threat of post-operative infection, once the great scourge of surgery, plummeted. Surgeons could finally attempt longer and more complex procedures with far less fear that bacteria would undo their work in the days that followed. The combination of sterile technique, anesthesia, and antibiotics made possible surgeries that earlier generations of doctors would have considered reckless fantasies. The first decades of the 20th century were still dominated by the classic heroic operations, amputations, appendectomies, hernia repairs, but the middle of the century opened doors to whole organ surgery. In 1954, a Boston team led by Joseph Murray performed the first successful kidney transplant between identical twins, proving that an organ could be removed from one person and function in another. By the 1960s and 70s, surgeons were attempting liver, lung, and even heart transplants. The first human heart transplant by Christian Barnard in 1967 stunned the world. These feats demanded exquisite surgical skill and a new understanding of the immune system, since the recipient's body often tried to reject the foreign tissue. The development of immunosuppressive drugs later on would help transplants become routine rather than miraculous one-off events. While transplants pushed the boundaries of possibility, other advances refined everyday surgical practice. Specialization became the hallmark of modern medicine. Neurosurgeons for the brain and spine, cardiothoracic surgeons for the heart and lungs, orthopedic surgeons for bones and joints, pediatric surgeons for children. Each field developed its own tools, techniques, and training, allowing ever more precise work. By the late 1970s and early 1980s, another quiet revolution was underway: the rise of minimally invasive surgery. Instead of large incisions that left long scars and required weeks of recovery, surgeons began using slender instruments inserted through tiny openings in the skin. Laparoscopic or keyhole surgery employed a miniature camera attached to a fiber optic cable, projecting the view of the inside of the body onto a monitor. The gallbladder, once removed through a long abdominal cut, could now be taken out through 3 or 4 small punctures, reducing pain and scarring and sending patients home in days instead of weeks. These techniques spread quickly to many types of operations: hernia repairs, gynecological procedures, joint surgeries, even certain heart valve repairs. Technology didn't stop at cameras and scopes. By the end of the century, the first systems for robotic-assisted surgery were developed. The surgeon no longer had to stand bent over the operating table. Instead, they sat at a console, guiding slender robotic arms equipped with tiny instruments that could pivot and rotate more delicately than a human wrist. These robots did not replace the surgeon. They amplified the surgeon's precision. A tremor that might cause a human hand to waver a fraction of a millimeter could be filtered out by the machine's stabilizers. For operations deep in the pelvis or around fragile nerves, this new steadiness was transformative. Other breakthroughs reshaped both planning and recovery. CT scans in the 1970s and MRI scanners in the 1980s gave 3-dimensional pictures of organs and tumors before a scalpel ever touched the skin. ICUs and better anesthetic monitoring equipment allowed doctors to keep patients stable during hours-long operations that would once have been fatal from shock or blood loss. Prosthetic joints and surgical steel plates let orthopedic surgeons rebuild shattered hips, knees and spines, restoring mobility to the injured and elderly. These decades also saw new ethical questions arise alongside the technical triumphs. How far should surgery go in prolonging life, in altering appearance, in transplanting not just organs, but tissues like hands, faces, even uteruses? The answers evolved as techniques improved and public attitudes shifted, but the very fact that such questions could be asked at all showed how far surgery had come from the desperate amputations of centuries past. By the closing years of the 20th century, an ordinary patient entering a well-equipped hospital could expect a level of safety and precision unimaginable even 50 years earlier. Broken bones could be fixed with screws and plates, failing hips replaced with artificial joints, blocked arteries bypassed with veins borrowed from the patient's own leg, diseased corneas swapped for healthy donor corneas to restore sight. Babies born with heart defects that would once have been fatal within days could be operated on successfully and grow to adulthood. Even the operating room itself had transformed, bright, sterile, humming with electronic monitors and ventilators, a place where dozens of professionals, surgeons, anaesthetists, nurses, perfusionists, worked in choreographed harmony. The century that began with surgeons still wearing dark street clothes over unconscious patients ended with highly trained specialists using imaging guidance and robotic arms under the glow of fibre optic lights. The journey from the rough-hewn amputation tables of the 19th century to these sophisticated suites had taken barely 100 years, a blink in the span of human history, yet enough to change the prospects of anyone in need of an operation. Standing at the threshold of the 21st century, surgery had become not merely a desperate measure, but a routine promise. To repair, to replace, to transplant, to heal. And even that was not the end of the story, because the next era would bring its own marvels: finer instruments, genetic tools, regenerative medicine, and surgical robots with ever steadier hands. But those belong to the current age. From flickering gas lamps to robotic hands steadier than our own, the 20th century turned surgery from a last resort into a fine-tuned science. It's weird to think that seeing inside the body once required a scalpel, and now it just takes a scan, or that a heart could be removed and restarted in someone else, like jumper cables for the soul. This history may sound wild, but it's all true, and that's the kind of weird I live for. I'm expertly weird. And if you think that was strange, just wait until you see what the future of surgery looks like. Stay curious.